Hello and happy Teach Me Tuesday. My name is Lisa Houston and I'm a clinical nurse educator in the NICU. And today for our Teach Me Tuesday, we're going to kind of go on the theme of the CBC. Since we talked about CBCs last week and sepsis and left shift and kind of what we're looking at with our neutrophils, thought we would just look at a different aspect of the CBC today and kind of talk about our hematocrit and hemoglobin and how that helps determine when a baby needs a blood transfusion. So let's jump in. So blood transfusions are this procedure. I was actually spending a lot of time kind of thinking about my own practice. And I was talking to a nurse on our unit the other day, and she was like, I just gave a blood transfusion. I haven't done that since September. And it's crazy because in a NICU where our average daily census is, hovers around 90, you would think that we would see blood transfusions more, but back when I started my practice 20 years ago, we did blood transfusions frequently. And now we just don't do them as often. We really are much more conservative with giving blood. And I just thought it was such an interesting dichotomy of kind of what we used to do and what we do now, which we're going to dive into a little bit more. But we give these transfusions because sometimes blood loss, like we give most of our blood transfusions probably in the first week of life. A lot of that blood loss from either the delivery, emergencies, us taking blood from the babies. Those are kind of those reasons that we're often giving blood at the beginning. I personally am a hematocrit person. I've always worked places where we looked at the hematocrit, so hemoglobin levels I am not as familiar with as hematocrits. One of those things, maybe it's regional, I don't know, but if you tend to use hemoglobin more, I'm sorry because I'm probably going to say hematocrit a lot today, so bear with me. But we've also really started looking at this idea of what are the symptoms of the baby telling us in regards to do they need a blood transfusion? And once we know they need that blood transfusion, how can we make sure we're giving it to them in a safe place, in a good PIV or umbilical line or a central line that can take blood? Are we watching them for signs of transfusion reactions, which I've never seen one? So less common in the baby. But let's talk about those normal blood counts. Here's another one of my new favorite things, these charts. Now that I figured out how to do them, I'm just like, can't stop myself. So these are a general framework, right? Like this is not exactly what's happening with every single baby all the time. Your unit may have some different numbers that they see as normal, but we're also kind of adjusting it as we're going on. And we're really looking at that blood transfusion on what can we do to prevent the need for a blood transfusion, and how can we make sure that when the baby needs it, we're giving them the right amount. So in a full-term baby, again, when we're talking about our hematocrits, we're really seeing those crits, especially in that first week of life, anywhere from 50 to 60, especially with delayed cord clamping, we're seeing higher hematocrits. And we really want that hematocrit to be above 30 in any gestational age. And then we're going to talk about, as we move through here, why we would want it to be higher at different parts of their life. The platelets are also interesting. We have a new protocol. I guess it's not that new in our unit. It's a few years old. And really this idea of platelets, I used to remember kind of we would give platelets only if their counts are like less than 25,000, but now we're giving it a little bit more frequently if it's less than around 50,000, maybe 200,000, depending on what the baby's doing. So really thinking about what's the baby's symptoms, how old are they in weeks and days of life, and what are they telling us they need. But why are these babies at higher risk for needing, a transfusion? So anemia prematurity, this is just like everything else. I love to just say this, like if the baby's premature, every organ is premature. We are asking the organs to do things out of order. It's so interesting to think about that. Like the skin, just think about the skin, this huge organ on our body, which we talked about when we talked about skincare. In utero, it really isn't doing much, right? It doesn't really have this big important job. And then the baby comes out early and all of a sudden it has to prevent us from infection, keep the fluids in, help maintain the temperature. It's wild. And so every organ is experiencing this too, and the bone marrow is not spared from that, right? The bone marrow is being asked to do things kind of out of order or before they were supposed to, and so they have that problem. They have blood loss primarily from how much blood we take from them. We used to keep a sheet back in the paper charting days. That's how old I am, where we would every day we'd write out how much blood the baby would get out, which is interesting because it wasn't like when we got to a certain number that we were like, oh, you need a transfusion. But it did kind of come into our story of like, okay, now they're showing us these signs and symptoms. Their hematocrit has gone from 34 to 30, and we've taken 15 mils of blood. Maybe it's time to give 15 mils of blood back. Babies that have had surgical procedures are going to be at higher risk for needing blood, infections, and sepsis. So we talked about sepsis a little last week, as you may recall, but really thinking about this idea that the bone marrow is just not going to be able to function to its highest capability, especially if it's trying to pump out neutrophils because it's fighting an infection. It's not going to be pumping out our red blood cells. Obviously, we have some hemolytic disease of the newborn. These are those babies that you're also transfusing or even considering an exchange transfusion or giving IVIG to for the RH incompatibility because of that rapid breakdown of the red blood cells. I've seen, a couple exchange transfusions in my lifetime, in my career, but definitely seen babies who we've given IVIG to or have needed a blood transfusion, even those term babies that are like screaming their heads off. And then we have some of our genetic or acquired disorders. We had a baby once in the unit that I work on, this was years ago, that was actually born with a form of leukemia. And so at first when the baby came out, we were giving all these blood products, and it turns out that she had some sort of leukemia and had we had all of our hemonc and everybody involved in this situation, and it was a very sad story. But kind of that's an normal thing is to have this term baby who is requiring multiple blood transfusions, so it caused us to dig deeper. So we know what our normals are. We know why we're losing blood or we might need a blood transfusion. So what does the evidence tell us? So you know how much I love evidence. I wrote down all of my resources so I would remember to post those or give them to you if anybody was looking for them. So one of our studies is the red blood cell transfusions in preterm infants and neurodevelopmental outcomes at 2 and 5 years of age. So the negative correlation between red blood cell transfusion and neurodevelopmental scores. So essentially that means that if you got a lot of blood transfusions, we weren't having this terrible outcomes that we thought that we were having. And if we allowed their hematocrits or hemoglobins to be a little bit lower, it did not affect their neurodevelopmental outcomes. So that also is our next one, higher or lower hemoglobin transfusion thresholds for preterm infants. So no difference in mortalities or long-term comorbidities in infants treated sooner with blood to maintain higher hemoglobin levels. So basically saying, hey, we're trying to give these babies blood and to see if it would prevent any long-term outcomes, and it didn't change anything. So essentially what they're saying is a higher hemoglobin threshold for transfusion was associated with an increased number of the transfusions. So, hey, we want our hematocrit to be 34, 35, whatever. We had to keep giving the babies more blood, but it did not improve survival without neurodevelopmental outcomes at 22 to 26 months corrected age. So basically saying, even if we try to keep their hemoglobin and hematocrits high, it does not improve their outcomes. And then finally, we have this restrictive versus liberal red blood cell transfusion thresholds in very low birth weight infants, a systemic review and meta-analysis. So love meta-analysis. It's like they pull in all the research and kind of put it all out there together. So found that giving blood less often at a lower threshold, so saying, hey, we're not going to give blood until we get down to 25, did not show increases in the risk of death or major short-term neonatal morbidities. So essentially what they're saying in all of these studies, and we have the top and the pints and the ETTNO, no, I don't know if that has like a cute name to it. All these studies are essentially saying, hey, we don't need our hematocrit and hemoglobin to be really high for these babies to have good short and long-term outcomes. So because of that, looking at all of that, this is a little chart that I created based on the evidence that I have read and protocols I have seen. So this is a compilation of different resources and trials and should be used as an example guideline. This is not something that came from one study. But essentially what it's saying is, hey, let's have numbers. Let's give numbers so that people understand where we're going. So that I think especially this idea of the critical versus not critical. So it's saying, hey, we're not just going to look at a number. We're going to look at that number and say, what's going on with the baby? Is the baby telling us that they don't have enough circulating red blood cells to be able to be stable? And if that's the case, then we need to be transfusing. So in the first week of life for the hematocrit, my favorite, we are really going to say critical, a low level is when we're less than 32. I've seen anywhere really from 34 to 30 on this. Mostly, in most of the evidence that I was reading, it was mentioning 32 to 34. So really this idea of 32. And so what does critical mean? The MAP being greater than 8 on the ventilator. I thought that was so interesting because in some that was saying mechanical ventilation, like if you're on any mechanical ventilation, and others it's saying, hey, you might be on mechanical ventilation, but if you're weaning on everything, maybe you're not as unstable. Congenital heart disease, we know those babies are at higher risk. CPAP, oxygen greater than 35%, or on nasal cannula greater than 1 liter. That's the first week of life. And if you're looking at your hemoglobin, really, if it's less than 12.5, seen as low as 12, as high as 14. So again, we're in a range here. Non-critical is really those stable babies. And this is where I think we kind of get the most pushback and questions as a NICU educator. And I will say, I've heard less over the years, and I think that's just more global acceptance. And that's the greater than 3 week. Okay, so this is like our 6-week-old X28 weeker whose crit is 24, and we just can't get them to bottle feed. But they're just on like a half liter or a liter. They're tolerating their feeds. Maybe they're eating some bottles, and everyone's like, should we transfuse them? We got to look at our reticulocyte count, right? So remember, our reticulocyte count is telling us how well the bone marrow is doing. And if you have something that's saying, I'm doing really good, I'm doing really good, I'm doing really good, and then we transfuse you, it goes down back to the bottom and it has to rebuild because that transfusion has come in and said, we don't need you to do your job, so you can just quiet down. A little bone marrow, a little reticulocyte count. We don't actually need you right now. And so then the retics drop, and then again, it has to rebuild. So that blood transfusion comes in and it's kind of killing this. So if you've got a good reticulocyte count, the baby's producing the red blood cells, it's going to catch up over time. And so looking at this critical versus non-critical threshold really says to us like, hey, here's a guideline. Let's see what the baby's doing. And if we can avoid a transfusion, let's try to avoid it. Less transfusion is less fluids, less exposure to donors, and it's not changing our long-term neurodevelopmental outcomes, so let's not do it. So what's our job as a bedside nurse? So we're going to first watch for those signs of low hematocrit. We used to do a CBC every Sunday night labs. Anyone? On all babies. And then we wonder why their hematocrit's low. I don't know, maybe because we're taking too much blood. We figured out not the best practice. So many things. So we're watching pallor, tachypnea, tachycardia, apnea, lethargy, poor feeding, these things that are telling us like, hey, maybe something else is going on. They decide to order a transfusion. So most likely you're going to get 15 mils per kilo as your order. You're going to give it over 3 or so hours, maybe 3 to 4 hours. We're going to use, babies can be type and cross, so we get blood that is specific to them. It decreases that risk of a transfusion reaction. Again, I've never seen a transfusion reaction. Not saying it can't happen, but I've just never seen it. So we're going to watch them. I think a lot of what I would think if I'm especially giving a blood transfusion to a 24-weeker, which again I think is the most common we're giving them to, is we're going to see that irritability, the change in the blood pressure, and the change in the breathings. I think that's really what we need to focus on is kind of what we'd be paying attention to. When you're giving that blood, the blood cannot run in with any other fluids. It is compatible with normal saline, but it really shouldn't run at the same time as that. And as you can see in this picture here, this is an IV where the blood is just going into that one thing. Often we have to start an IV for this because, as our PICC lines in the NICU are just too small to be getting blood. So if you have a dual lumen UVC, you could give the blood in one of the lumens while running your other fluids, but you never want to run blood with D10. The sugar in the D10 will lyse the cells and it will make your blood transfusion just not really doing anything for the baby. It's also important to know that in an emergency, we might have to give blood in a situation in a place that we don't always want to. I've given blood in a UAC before because a baby was essentially, not doing well, dying, and that was the only access we had, and so we did it. And so in those situations, that's where the benefits just outweighs the risk, and you have to do what you have to do. But primarily, you're going to be putting in an IV or using like a dual lumen UVC. So when we're talking about blood transfusions, what are some other things that we can think about? So we're going to try to prevent the need for blood, so minimizing blood draws, giving the baby iron supplementation, delayed cord clamping. When I said we used to give all of these blood transfusions, we don't do that as much anymore. Delayed cord clamping is a big part of that. These babies come out more robust with higher hematocrits. We need to think about ongoing transfusions because we want to reduce the number of donors. Again, we used to give like 15 mils per kilo over 4 hours, wait 4 to 8 hours and give another 15 mils per kilo, or we would top the baby off while they still had their IV. Those automatic repeat transfusions, we just don't do that anymore. We know better, so we're doing better. Some future work that's out there, one of these things, the last one, I was like, what are we talking about? It was crazy to be reading these research. But EPO, erythropoietin, has a very interesting feeling to people in the NICU environment. And this idea of kind of, hey, what can we do? If we give them the shots, that's also increasing a pain thing for them. Is it helping? We know that there was a study done on EPO and HIE, and it showed that it did not help their outcomes. So there's also controversy on, does EPO actually increase their bone marrow to produce more red blood cells, and are they having less transfusions? And I think that the evidence is still coming, and it's still mixed. So having some standard protocols like the one I was showing you, kind of what is your unit defined as their critical and non-critical threshold, whether it's hematocrit or hemoglobin. I went to the NAN conference, as you know, in September, this past September, and there was a whole lecture on hemoglobin levels. And it was by a brilliant doctor, and I was like furiously taking notes because it's just so many things I hadn't really thought of before, and kind of what they were watching and when it peaks after and when it peaks before. But really that if we aren't doing the same thing from provider to provider, we're setting the baby up for failure because of what the bone marrow is trying to do. And then finally, artificial blood products. Lots of interesting things coming out about artificial blood products, so stay tuned for that. I was like, this is wild. But that's things that is out in the evidence being studied right now, so we might see it soon. As always, we want to talk about our parents. So our parents do give informed consent for us to give blood, unless it's in an emergency situation, kind of at birth. Sometimes there's emergencies and we do give emergency blood, but we want to make sure we're educating our parents about the reasons for transfusion, the procedure, and any potential risks. These were some phrases that I just thought, I call them my elevator speeches, the things I kind of repeat over and over again when I'm telling families about things. I thought I'd write some of them down. Go ahead and, screenshot this if you want to. I realize I cut my own slide off right now. Here we are being normal human again here. But really this idea that your baby needs a blood transfusion because the red blood cell count is low, the reasons it could be happening, why red blood cells are important, how much blood we're going to give them, that it's safe, that it's screened, it's prepared for them, and that most babies tolerate the blood transfusion very well. So blood transfusions are common and essential treatment in the NICU. They help increase the oxygen carrying capacity of the baby's blood and improve their energy levels, their growth, their development. We've learned that if we do need a transfusion, it's safe to give it, but can we give less? Can we lower our threshold for a transfusion? Because we know that the neurodevelopmental outcomes will be equal or will be similar. And then we want to keep our parents well informed and help them understand this process. Thank you for joining me today on today's Teach Me Tuesday. I will see you next week for another episode of Teach Me Tuesday. Have a great day.